So, first of all, we are seeing as an Ayurveda Medical College, we are getting a lot of cases with the hemiplegia, people who are suffering from residual palsy. So, my question, the first area we want to differentiate is the area of acute onset weakness, especially related to cerebrovascular accidents. So, my question to you, sir, is to differentiate the different types of cerebrovascular accidents as per the vascular territories.
Good morning. First of all, any acute onset neurological problem is vascular unless otherwise put. So, if you say that if you see a patient with acute onset of weakness, in almost all probability it is a vascular event. Stroke, in general, you can differentiate to two types. Either it is ischemic. I don't think you need to write down this. It's there in your textbook. Just listen. In 80% of the cases, it is ischemic stroke, and 20% of the cases, it is hemorrhagic stroke. So, previously, before the era of imaging, around 30 years back, the diagnosis of stroke was mostly clinical, as per the features of the onset of the stroke. But after the invention of CT scan and MRI, most of the time, if we see that we may make a diagnosis of ischemic stroke, but on the CT scan, it will be a hemorrhagic stroke. So, clinically, it's not always possible to differentiate ischemic stroke from a hemorrhagic stroke. But there are some certain features which you can use to differentiate clinically whether it is a ischemic or hemorrhagic stroke. Ischemic stroke, there are two types. One is embolic stroke and another is thrombotic stroke. Embolic stroke means embolus arising from either heart or from the carotid territory going and blocking any vessel. So embolic stroke usually will be acute onset, and the weakness of the patient will be maximum at the onset. But on the contrary, the thrombotic stroke is usually evolving stroke in evolution. Patient present with minimal weakness in the morning, after few hours, it becomes more and more weak, and he develops full-blown stroke in another 2-3 hours. That is the usual story of stroke in evolution. And such patient can have history of transient strokes also. They can develop initially with the transient ischemic attacks. Suddenly they will develop hemiparesis or hemiplegia, which improves after some time and will become totally normal after 10 to 15 minutes. But again the same thing happens again and again, and ultimately they will develop a full-blown stroke. So transient ischemic attacks, by definition, it lasts for 1 hour, but usually it lasts for about 5 to 10 minutes only. And if you see a patient with a history of acute transient ischemic attack, you should take it very seriously, because when you see the patient will be totally normal. And you may give some medicine also. And they will come back with you and telling that after your medicine, the patient develops full-blown stroke. So you should be very careful in dealing with such patients, and you should very clearly give the message that it should be treated immediately, otherwise you have a chance of developing full-blown stroke. Okay, so treating a patient with completed stroke is easy, but the patient with evolving stroke is also difficult. They will tell after some time, he came walking to the hospital, now he is totally hemiplegic. So the evolving stroke also, it's very difficult. Patient can have only minimal weakness at the time of admission, but gradually they may progress to full-blown stroke. So when a patient with a minimal weakness or patient with a history of TIA, You should be very careful and give the message that this stroke can progress. There is a risk of progression of the stroke, and after around 24 to 48 hours only, you will be able to tell how much it will progress further. Okay, so ischemic stroke usually develops slowly and go into full-blown stroke over hours or 1 to 2 days. On the contrary, embolic stroke develops all of a sudden. So also hemorrhagic stroke. Hemorrhagic stroke also usually develop very acutely. Most often they will have associated headache also. So acute severe headache and developing hemiplegia, usually hemorrhagic stroke. But it is not 100% sure. It can occur in ischemic stroke as well. Okay, and sometimes even the hemorrhagic stroke also can evolve. Sometimes at the time of admission there will be minimal bleed, but the bleed can increase further and develop worsening of the symptoms. So acute onset headache and weakness, usually clinically may hemorrhagic, but it can occur in ischemic stroke as well. But one point which you should be very careful is that subarachnoid hemorrhage, that you should never miss, because the history of subarachnoid hemorrhage is that patient will present like this: sudden onset headache, especially in the occipital region, and after some time patient may be normal also. But if the patient says like this, abrupt onset, that history is abrupt onset headache, then you should be very serious, because subarachnoid hemorrhage most of the time initially first only warnings brief, that will be minimal. Patient can have minimal symptoms or maybe no symptoms, but 30% of patients with subarachnoid hemorrhage later on develop full-blown rebleed. 30% will have a risk of rebleed within next 2 weeks. So if the patient comes to you with a history of abrupt onset headache, even if the patient is asymptomatic, you should consider the possibility of subarachnoid hemorrhage, and you should warn the patient that he can develop a second bleed, and most often the second bleed will be very massive and patient may succumb to the disease. Okay, so the history of subarachnoid hemorrhage is usually abrupt onset, and if the patient says like that, you should investigate irrespective of whether the patient has symptoms or not at the point of your consultation. Okay.
One more question in this area is regarding the territory where the vascular deficiency happens. That means which arterial system is affected, like ACA territory, BCA, MCA territory. So can we differentiate the strokes clinically and find out which territory is affected?
Clinically, it's possible. Usually, MCA territory present with the hemiplegia without aphasia, depending on the side of the involvement. So, if the patient comes with acute onset right hemiplegia with aphasia, then you can make sure that it is MCA territory stroke. If it is only Broca's aphasia and with the minimal weakness, there is no sensory aphasia, then you can mostly it is due to anterior division of MCA clot. But if the patient has got only sensory aphasia, then it is posterior division of MCA, middle circular artery. And if the patient is having global aphasia, dense hemiplegia, and patient is slightly drowsy, then it is middle circular artery stem occlusion. Then if the patient comes with acute onset weakness where lower limb is more involved than the upper limb, with or without involvement of the bladder, then it is most likely ACA territory infarct, anterior cerebral artery infarct. And when the patient presents with acute onset visual problem, then it is posterior cerebral artery. PCA territory infarct usually present with the homonymous hemianopia. So usually patient with acute onset visual problem. They may not be able to differentiate whether it is homonymous hemianopia, but they will say loss of vision of one side. Because in the left PCA territory infarct, patient will have right homonymous hemianopia. They will have right half of the visual field is lost. But they will identify it as right-sided visual loss. Right eye is blind. Because in the right homonymous hemianopia, majority of the portion is affected on the right side and only a small portion on the left side is left. But for the right visual field, the small portion is only very minimal, so patient will not identify that. So, right homonymous hemianopia for a patient it is right eye blindness. But if you carefully examine, you can differentiate that patient has vision on both eyes. It is only a field defect. So, if the patient presents with the acute onset visual problem, it is PCA territory infarct. And also, I told that when the patient presents acute onset headache, it's usually hemorrhagic. But there is an exception. And some PCA territory infarct, they will present acutely with the severe headache. Even they may not identify the visual field defect also. They present the severe headache. That is as usually a feature of PCA territory infarct. So also the PCA territory, if it is artery to the cerebellum is involved, again patient has got severe headache, and also they can have associated ataxia or diplopia, dysarthria or dysphagia. Okay, so you can have a meaningful conclusion that whether the artery territory is involved is either FCA or ACA or PCA as per the clinical manifestation.
So regarding the weakness, here up to this we have discussed acute onset weakness. Now the motor tract actually extends from the motor area in the brain up to the neuromuscular junction. So we will see a lot of syndromes starting from multiple sclerosis, MND, GBS, transverse myelitis, and all sorts of all of this resulting in some sort of weakness and other symptoms in the patient. So can we differentiate on the basis of the different levels how this diseases evolve, how this express in the patient clinically, and how can we differentiate them? So first of all, my question is regarding multiple sclerosis.
Multiple sclerosis usually presents not very hyperacute, can be acute and slowly progressive. It's not as dramatic as a vascular involvement. Patient can have some paresthesia on the first day, and 3-4 days later patient can have weakness of one side, or mostly they can present with the optic nerve involvement. The multiple sclerosis, again, the symptom depends on the area of the neural tract which is involved. If it is in the spinal cord, usually they will present with the weakness of the limbs. If it is in the dorsal or below, it is in the lower limb weakness. If it is in the cervical region, it is present with the quadriplegia. Here also, the onset is not very dramatic, and it will be progressing over 2 to 3 days time. So, if the patient develops the weakness on either side of the body, both the right and left side, is usually it is part of spinal cord involvement. If it is strictly on one side, involvement is in the brain. So the multiple sclerosis can affect any any part of the neuraxis. If it is in the brain, it's usually one side. If it is the spinal cord, usually both sides is affected. And most of the time, the multiple sclerosis starts with optic neuritis, either unilateral or bilateral.
Can you have some additional points regarding the investigations which can be carried out in the evolving period to differentiate this issue?
Nowadays, MRI is a standard choice. CT scan cannot give any result in the demyelinating disease, and so also the initial part of ischemic stroke. So, the role of CT scan is only if you suspect bleed. If you suspect ischemic stroke or whether it's a part of demyelination, MRI is the choice. So MRI most of the time will be able to tell you whether there is any involvement of the neuraxis.
And the evolution of plaques that can be visualized only later in the MRI or acutely also.
Whether the plaques actually what you are looking for the MRI, whether it's an active lesion or it's a old lesion. Active lesion, most of the time it is contrast enhancing lesions. So that we will be able to see the initial 2-3 days itself.
Okay, sir. And sir, regarding the other diseases, coming to the terrain of motor neuron disease. Motor neuron disease also we are getting a lot of cases, and can you differentiate the different varieties of motor neuron disease, how it evolves, and what is the progression and where will be the what will be the endpoint stages?
Motor neuron disease is a degenerative disease, so it is evolving very slowly. Patient will not present with the history of weakness of 1 month duration, 2 months duration. It's not like that. Usually over the months, patient usually they may notice minimal weakness, some twitching, which he may not notice also. And over the next few months only they will start some weakness, and can depending on the type of MND. Usually the MND you can differentiate whether it is different types is pure UMN type, pure LMN type, or mixed. Pure LMN type is affecting the spinal cord is usually spinal muscular atrophy type, that is usually seen in the younger children. Pure motor affecting the bulbar is the bulbar palsy, bulbar area bulbar palsy, that is usually very common. And pure UMN type is known as primary lateral sclerosis, that is usually not very common. Most of the time, MND is a mixture of upper and lower motor neuron disease. So they will have features of LMN weakness like vesicle lesions, wasting, and at the same time they will have features of UMN like brisk reflexes and spasticity. So if you see a patient with a combination of LMN and UMN without any sensory symptoms, usually it is very easy to diagnose. You can make a diagnosis of motor neuron disease. But the problem is that most of the time, the initial phases, it may be difficult to diagnose. In the evolving phases of motor neuron disease, sometimes you may not be able to confidently say it is due to MND. Sometimes the cervical myelopathy, cervical spinal cord lesion can exactly present with the evolving MND. So before making a diagnosis of MND in the initial phases, you have to rule out compressive lesions in the cervical spine, because it can exactly mimic as motor neuron disease. So also the presence of sensory is usually against a diagnosis of motor neuron disease. But mostly motor neuron disease is usually seen in patients of around 50, 60 like that. So most of these patients will have additional causes for neuropathy, either diabetic neuropathy or part of the age. So the moment you say there is some symptoms, you should not rule out that it is not anything, because the neurosensory symptoms may be part of the other disease that can coexist in that age. So in the evolving phase, you may get confused and you will not be able to confidently say that it is motor neuron disease initially. But when the disease evolves, it is very easy to make a diagnosis of motor neuron disease.
Sir, you talked about bulbar palsy. So, bulbar palsy is very special with reference to the patient will not be having no other weakness, but it will be starting with the difficulty to swallow and talk. Can you have some additional points regarding that? Regarding its prognosis and other things.
Again, it is a slowly progressive disease. Mostly patients present with initially with the slurring of speech and some difficulty to swallow, and it will gradually progress over months to years, not 2 years, by around 8 to 9 months. And by the time the patient will not be able to swallow his own saliva, and patient will present with drooling and recurrent episodes of aspiration pneumonia, part of choking. And at this point of time, patient will have severe wasting of the tongue. Patient will not be able to put out the tongue, and if you tell the patient to open the mouth, mostly they will have drooling, lots of saliva pooling there, and the tongue will be wasted and fasciculation, just like a bag of worms. And he will not be able to put out the tongue. And here also, in the final stages of FND, diagnosis is very clear cut. There is nothing there is no differential diagnosis. But again, in the initial phases of evolving bulbar palsy, you have to consider other possibilities like bulbar myasthenia, which is very treatable disease. So you should not miss bulbar myasthenia, the initial phases of the bulbar palsy. In bulbar myasthenia, there won't be any wasting or fasciculations, which may not be seen in the early phases of bulbar palsy also. And usually there will be a history of fatigability. If the patient is talking too much, after some time the become sound will be slurred and voice will be of loud tone. But if there is a clear-cut history of fatigability, in the absence of wasting and fasciculations, it can be a myasthenia is a possibility. But usually it will not cause confusion once it is evolved in the later stage, where there is definite fasciculations and wasting.
Okay. So there is another clinical entity called pseudobulbar palsy. So please have some points regarding that.
Pseudobulbar palsy, as I mentioned previously, it's a human counterpart of bulbar palsy, bulbar motor neuron disease. So here, actually there won't be much wasting, and speech is spastic dysarthric speech. And if you ask the patient to put out the tongue, they will be able to put out, and there won't be much wasting and fasciculations. And usually such patients present with the emotional incontinence also. Usually they will have emotional incontinence. And again, pure pseudobulbar palsy is occurring in the initial phase only. Subsequently, it will evolve into ALS. And I think that is
Okay. Now we are moving on to the terrain of transverse myelitis. Can you explain transverse myelitis and give its differentials?
Transverse myelitis means acute involvement of the cerebellum spinal cord. So usually history is acute only. Common duration will be around 3 to 4 days, and patient present with weakness. And depending upon the level of involvement, if it is in the dorsal region, so only lower limb is affected, and if it is in the cervical region, all four limbs is affected. And most of the time there will be a sensory level. Patient may say that below this level I am not able to perceive. Or if you examine, you can say clearly there is a sensory level. And usually there will be involvement of bladder. So if a patient presents with acute onset weakness which has evolved over 3 to 4 days with a sensory level and with bladder involvement, clinically it is a transverse myelitis. The only differential diagnosis of a transverse myelitis is hyperactive presentation is a spinal artery occlusion. Vascular cause also can occur. But it's not very common, and most of the time, 90% of the patients, it will be demyelitic disease, transverse myelitis. Among the demyelitic disease, there are actually two types which can cause transverse myelitis. One is part of multiple sclerosis, or other is NMO spectrum disorders, autoimmune mediated spectrum disease, neuromyelitis optica. So clinically also there are some clinical differential diagnosis, and comparing multiple sclerosis, NMO spectrum disorders, transverse myelitis has got severe involvement. And if you see the MRI, there will be extension cord involvement. Usually, multiple sclerosis affects only 2 or 3 segments. On the contrary, the whole cord may be involved in the NMO spectrum disorders.
So this NMO spectrum disorder is part of transverse myelitis.
It's a type transverse myelitis. It just means that myelitis
happening
inflammatory disease of the spinal cord. The cause is both demyelination only. One can be part of multiple sclerosis, other could be part of NMO spectrum disorder.
So it's divided like that. One is part of multiple sclerosis, other is NMO.
Yeah.
Okay. So any antibody laboratory panel specifically under tried for this NMO spectrum?
Yeah, sure. Only with the MRI and autoimmune studies only will be able to differentiate. If you suspect multiple sclerosis, you can see oligoclonal bands in CSF. In the CSF study, you can see oligoclonal bands. On the contrary, in the NMO spectrum disorders, you can even the blood sample, you can detect the presence of NMO antibody or MOG antibody. There are actually 2 types of NMO spectrum disorders. One is MOG associated disease, and another is NMO type. So MOG slightly in the younger age group, and children, it's usually affected children, and usually affecting the long spinal cord compared to other NMO spectrum.
So is this known as the MOGAD disease? MOGAD?
Yeah, MOGAD is MOG associated
Antibody.
That is usually seen in children, and actually there is slightly worse prognosis than acute.
Now we are moving on to the spectrum of Guillain-Barré syndrome, GBS, and its variants like Miller-Fisher, many other. And with the evolution, at the time of evolution, sir, how can we differentiate this Guillain-Barré syndrome and its variants with transverse myelitis and other varieties?
Again, Guillain-Barré syndrome is an acute presentation, usually evolved over 4 to 5 days, and initially can transverse myelitis is a differential diagnosis, and more than that you have to rule out other disease which can present acutely as lower limb weakness. Acute presentation of if the patient comes to casualty with a history of weakness of all four limbs since today morning, then you have more than the Guillain-Barré syndrome, you have to rule out hypokalemia, which can present as acute weakness. There is an entity called periodic paralysis, hypokalemic periodic paralysis, where the patient develops severe hypokalemia and weakness. Here the importance is that if you miss the diagnosis of hypokalemia, patient can die of cardiac arrhythmia. And if you diagnose hypokalemia, you can treat and the patient will start walking in 1 day. So, whenever a patient comes to casualty with acute onset weakness of either lower limb or all four limbs, and you have to rule out hypokalemia because it is very treatable and which is, if left untreated, has got high mortality. And once you rule out hypokalemia, then if the patient presents with a weakness of all four limbs, other possibility you have to consider is myositis, acute polymyositis or viral myositis, where the patient has predominant myalgia, even in hypokalemia and Guillain-Barré syndrome and even polymyositis can cause all severe myalgia. But severe myalgia is usually a feature of polymyositis. So, if you suspect polymyositis, you can ask for a CPK, which will be usually in thousands in polymyalgia, where in Guillain-Barré syndrome it will be normal. And other clinically, you can diagnose Guillain-Barré syndrome with the sensory symptoms. If the patient, most of the time the patient presents with paresthesia even before the weakness starts. On the day one, they will have paresthesia, and before the weakness starts. If the patient clinically has severe paresthesia and weakness, then almost the diagnosis of Guillain-Barré is certain. And how to differentiate from transverse myelitis and Guillain-Barré? Here, in Guillain-Barré, there is no sensory level, where there is definite sensory level will be the transverse myelitis. And in Guillain-Barré, there is no bladder involved, where most of the time bladder will be involved in transverse myelitis. Okay, and regarding the different types of Guillain-Barré, most of the time it is sensory motor, acute sensory motor polyneuropathy, and sometimes there are only sensory variant of Guillain-Barré, where the clinical presentation is only acute onset ataxia, sensory ataxia. And there are types of Guillain-Barré which is affected. Usually, Guillain-Barré affects from the lower limb and ascends up to the upper limb. And sometimes initial presentation may be facial palsy and ophthalmoplegia and ataxia. That type of called as Miller-Fisher variant.
Okay, so, you talked about Guillain-Barré syndrome. Belongs to the terrain of AADP. So, what about the CADP? How it is differentiated from the Guillain-Barré syndrome? Because it's chronic in onset.
Okay. AADP and CADPs will not come in the differential diagnosis. Okay. AADP is acute and CADP is chronic. Chronic inflammatory demyelinating polyneuropathy or CADP usually presents with the insidious onset, slowly progressive sensory motor weakness, starting from the lower limb and gradually ascends up to the upper limb. And it may take weeks to months to evolve. And patient usually present with difficulty to proximal muscle weakness in the form of difficulty to climb stairs or difficulty to get up from the floor. And the differential diagnosis of CADP is other muscle diseases like muscular dystrophy and myasthenia is very important differential diagnosis. Big girdle myasthenia is very important differential diagnosis. Okay, so the patient has, even though there is sensory motor neuropathy, clinically sensory involvement may not be very evident. Patient may not be, anyway patient will not have most of the time severe positive sensory symptoms. They will have mainly negative sensory symptoms like numbness and paresthesia, not hyperalgesia. And so if the patient has only predominantly motor weakness, muscle disease is a usually differential diagnosis. And also hereditary sensory motor neuropathy, Charcot-Marie-Tooth disease type also can present like CAD.
Okay, sir. Now we are moving on to the terrain of myasthenia. So it is present as an autoimmune mediated inflammatory disease at neuromuscular junction. So what will be the possibilities of identifying it in clinical?
The classical feature of myasthenia is fatigability. So if the patient most of the time may not be able to tell directly that this symptom person is the evening. But if you ask whether there is any fatigability, is there a symptom worsening over by the evening, then we will be able to tell you. And if the history of the fatigability is very definite, then you can make a diagnosis of clinical diagnosis of myasthenia. And when the patient is totally normal in between and patient is weak in the evening, then there is chance of myasthenia. Other diseases like CADP or muscle disease, muscular dystrophies and all, patient will have symptoms all the time. So if the patient is totally normal in between, then the chance of making a diagnosis of myasthenia is high.
So what are the laboratory and imaging which we use? Or imaging has no role in myasthenia. Laboratory panel is having a role.
Yeah. Myasthenia, in laboratory you have to look for CPK and other causes which can cause acute muscle weakness to rule out other diseases like thyrotoxicosis, hypothyroidism, and hypophosphatemia, hypomagnesemia, hypocalcemia. All these can be restored. This one. So laboratory diagnosis of myasthenia gravis. The first one is repetitive nerve stimulation, nerve conduction studies. Repetitive nerve stimulations shows classical decremental response. in the electrophysiological studies. So if you see that classically differential response, then the diagnosis of myasthenia is confirmed. And there are, instead of decremental response, there are some variants which can cause incremental response, that is known as Eaton-Lambert inverse myasthenia. So that is usually associated with paraneoplastic conditions, malignancy. So if you see an electrophysiological study reported as positive decremental response, then myasthenia is confirmed. And once you diagnose myasthenia, you have to look for antibodies against acetylcholine receptor. So acetylcholine receptor antibody, what percentage of acetylcholine receptor antibody is there, shows the degree of myasthenia involved. So sometimes usually normal titer will be around less than 5, than 2 or so. Most of the time it will be 15, 20, 30 like that. So positive acetylcholine receptor response, positive decremental response, diagnose myasthenia. And CPK will be normal, and all other metabolic parameters will be normal in myasthenia.
Okay, sir. Now the last direct is regarding the muscle dystrophies, which is the possibility of weakness. So can you distinguish different type of muscular dystrophies which is happening? Just give the patients that.
Muscular dystrophy is an again degenerative disease. So usually it will be presenting as insidious onset, slowly progressive disease. And most of the time, such it will be usually the starting age will be the school going period. So most of the time, parents will notice that kids while at school were not so active in sports. So though they say that symptoms start at the age of 20 years or 15 years, even before that, they were not very active during sports. So the symptom is starting very early, but it may not be very evident. So the muscular dystrophy, by the time of presentation, and it may, depending on the different variants, it can, the involvement can start at 5 years, 10 years, 15 years, 20 years, like that, depending on the type. So most of the muscular dystrophies are now, from the modern medicine aspect, there is no direct treatment other than supportive care. So depending on the different types of special muscular muscle involved, there are different types. Suppose it is facioscapulohumeral dystrophy or limb-girdle muscular dystrophy, or there are some other EUC myopathy, distal myopathy. There are different types depending upon which part of the muscle is mostly involved. And there are again here muscular dystrophy you should rule out limb-girdle myasthenia, because sometimes most of the patients branded as muscular dystrophy and left untreated will be having limb-girdle myasthenia, which is very potentially treatable. And so also the chronic polymyositis also can present as limb-girdle muscular dystrophy. In both, patient can have high CPK. Polymyositis and muscular dystrophy is patient will be high CPK. But usually for chronic polymyositis, there are other immunological parameters. Like if you check ANF profile, you can see specific autoantibodies. So before labeling a patient as muscular dystrophy, you should rule out treatable diseases like limb-girdle myasthenia, chronic polymyositis, or other metabolic myopathies also. Chronic hypocalcemia, hyperuricemia, thalassemia, like treatable diseases also you should put out.
Till we have completed the spectrum of weakness. Now my question is regarding the laboratory studies, especially EMG and NCS, in ruling out all these different varieties of weaknesses. How we can employ those studies for getting a conclusive evidence regarding particular diagnosis.
The investigation should be tailored. You need not to do all investigation for all patients, and whatever is your diagnosis and differential diagnosis, accordingly we can make investigations. You need not to do CSF study for all patients if you suspect muscle disease. If you suspect demyelinating disease, you have to do CSF studies. If you suspect demyelinating disease, you have to do EMG and nerve conduction studies. So depending upon whatever your suspicion and differential diagnosis, you can plan investigation accordingly. In general, if you see muscle disease, you can ask for nerve conduction studies and repetitive stimulations to rule out whether there is a possibility of CADP or literal myasthenia. Or you can ask for CPK if you suspect any muscle disease, which is potentially treatable. And you can ask for autoantibodies if you suspect autoantibodies like acetyl receptor antibodies if you suspect myasthenia. And depending on the diagnosis and different diagnosis,
CS also, sir.
CS, if you suspect CADP, you should do. If you suspect myasthenia, you should do. You can even the chronic polymyositis and if you differentiate between muscle disease and nerve disease, you can EMG is very useful. If you see denervation pattern, if you see myopathic pattern, there are two types of pattern, either neuropathic or myopathic pattern that can differentiate muscle disease versus nerve disease as per the electrophysiology report.
And CSF analysis also, this is a very valuable tool to differentiate the demyelinating diseases. There are certain points like albinocytologic dissociation, etc. are noted to differentiate the diseases. Can you brief about that?
Albinocytological dissociation means albumin is very high where the cell count is low. Usually albumin is high is an indicator of infection. This is to differentiate between infection and inflammation. If you see a patient with meningitis, you can see high CSF count along with the high protein. But if you see a normal cell count and high CSF protein, it is known as albinocytological dissociation. It is usually classical of Widdenberry syndrome. And also to some extent, the CSF count will be not that high in CADP. Cell count will be, protein will be around 300, 400 like that, the cell count may be around 30, 40 in CADP. In AADP also the CSF protein will be around 100 or 50, the cell count will be around 3 or 4. So such significant dissociation between cell count and albumin is usually indicative of CADP or AADP.
So now we finished that particular terrain which is terminating in weaknesses. Now we have some ODX questions.
Okay.
I invite audiences, anybody of you to have some additional questions or queries, comments regarding the points which are being discussed to up till. Because now we have completed a certain segment which is affecting the motor plant and I invite you to have some queries.
You can introduce yourself now.
Good morning, sir. Myself, Dr. Ashtamgam. I am higher MBA scholar, Ravi department, Nair-An College. Sir, I have told that you are making so many cases with the neurological disorders talk, and I have a question that you are suggesting your patients for our yoga therapy here, sir said, Rahul sir said, And also, how much we can see the effect of physiotherapy and yoga in this salvageable tissue phenomena, how much the effect of this we can see, and in patients as the response in so in your patients, and in which condition we can go through this, which cases of the condition of the patient, in which time we can go through this physiotherapy and all, or when we can suggest this.
We can suggest yoga to everybody because a disease, the definition of WHO is health is a state of complete physical, mental and social well-being. So every physical disease has got a mental counterpart. So if you can make the patients practice yoga, at least they will have, emotionally they will be stable, they will be more confident to handle the problem. So yoga is beneficial to all patients. Suggest yoga to everybody.
So can you see any changes in this phenomena? Has an effect in the neovascularization or in strengthening the neurons or the blood vessels?
I am not able to tell clearly from scientific basis whether there is any improvement in the penumbra or not. But what I said is feeling that if you make the patient happy, he is emotionally stable, he can behave better in the recovery phase. Okay. The patient is very upset and disturbed, and the recovery will be delayed. So the patient who are more happy and with a stronger willpower will have a better recovery.
And also I have a question that ALS plus syndrome, how much can see your patient, if patient with the ALS plus syndrome, the frequency of
ALS plus means?
Without this, rather than this UMN and element features, how much we can see this patient associated with dementia and
Yeah, usually ALS is, most of the time it is isolated only. Typical motor neuron disease is usually isolated with it is affecting only on the motor tract. But combination of other extracerebral symptoms is not very common. So if you see motor neuron disease patient, 99% will be pure ALS without any other neurological body.
last question, that in ALS, the markers like inclusion bodies, in all cases can we see that, or in which case we can see this inclusion bodies?
Usually the diagnosis is clinical, and these other investigations are usually only for the investigation purpose. So we don't usually investigate all such patients with the diagnosis is clinical and electronic.
Hello sir, my name is Nair-An. I am working as a medical officer under National Association. Sir, my question is, while examining sensory system, that is subjective, mostly subjective. So at the same level, at different point, patient feel two different outcomes. So why is that happening? And also like testing vibration sense like that. They may sense distally but not proximally. So is there any wrong in the examination?
Sensory examination, usually I used to say, it's not very reliable at all. If you examine the same patient at different times, they will give different answers. So there are different indications where the diagnosis you can make sure. The indication just like previously I mentioned the sensory level. That you can check, patient will be very clearly able to tell. And sensory ataxia, patient you can specifically tell whether there is any incoordination or not. Otherwise, most of the time sensory examination is not very reliable. If you ask 10 times, they will say, 10 times they will say yes. Okay, so it's sensory examination most of the time is, you should not give too much importance. I don't say that you shouldn't examine, but if your whole diagnosis is not fitting with your sensory examination finding, you can ignore sensory examination finding.
Good morning, sir. I'm Dr. Ashtamgam, Assistant Professor from Pharmacy School of Rahul. So my question is, when you see such so many neurological conditions, and when you approach them with your science, where do you exactly feel that Ayurveda can squeeze in, and what, from your perspective, where Ayurveda can help?
Yeah, I feel most of the acute medical condition has to be treated by modern medicine, because there is modern medicine has got a definite edge. On the contrary, most of the degenerative disease, when there is no specific treatment modalities so far invented, Ayurveda will be having a role. Like motor neuron disease, we don't have any specific treatment. Muscular dystrophy, we don't have any treatment. And in some areas, like Parkinsonism, can have effects from both modern medicine treatment and Ayurveda. So, in general, when I say acute presentation, stroke, and AADP, acute myositis, such patient and demyelination, such patient, it is always better to get treated from modern medicine side. And you can treat stroke patients once the acute phase is over. Patient has evolved, then the Ayurveda has a role in the rehabilitation. Because especially in the case of stroke, the brain is dead. So if you can intervene at the earliest, you can salvage small brain better. So if the initial precious period is lost, after 1 week, actually in the treatment of stroke, we don't have nothing much to offer. So all the treatment in the initial cases are here. So acute cases, modern medicine has got a better role. The chronic cases, but the acute case is over, Ayurveda has always offered.
Okay. Now we are moving on to the section of involuntary movement disorders. So, sir, regarding the involuntary movements, now we are getting a lot of questions in that area, right from the Parkinson and the Huntington's chorea. So all those areas, sir, can you just brief the pathogenesis that is happening behind the scenes, how this involuntary movement starts?
Involuntary movements are basically extrapyramidal disorders. The most common extrapyramidal disorder we come across is Parkinsonism. So, it is the dopamine deficiency and cholinergic preponderance. That is the usual basic pathology. Dopamine is low and the acetylcholine is high. So, the basic treatment will be to improve the dopamine level and suppress acetylcholine level. That's why this is usually these dopamine level is maximum in the basal ganglia. Basically, these are basal ganglia degeneration, which leads to loss of dopaminergic neurons, and there is hyperactivity of the acetylcholine. So, in Parkinsonism, the basic principle is to improve the dopamine level and suppress the acetylcholine level.
So coming to the spectrum of Parkinsonism, We have got Parkinson's disease and then the diseases which are more than that, Parkinson's plus symptoms. So how can you differentiate the IPD from other Parkinson's plus syndrome right at the time of onset? If there is a possibility.
Parkinson's disease and Parkinson's plus disease are both degenerative diseases, and when the involvement is strictly in the basal ganglia, it is idiopathic Parkinson's syndrome. When it is involved in multiple areas, it is Parkinson's plus syndrome. And most of the time, we will be able to make a diagnosis clear-cut as whether it is Parkinson's plus or Parkinsonism, idiopathic Parkinsonism or Parkinson's plus disease. When there is involvement of the extraocular movements, in the case of vertical gaze palsy, then there is it is known as Steven-Richardson syndrome or progressive supranuclear palsy. When there is associated autonomic imbalance or cerebellar ataxia, we call it as multisystem atrophy. When there is involvement of the cortex, cortical basal ganglia, even they will present it as dysarthria or cortical ant, and then it is known as CBG, cortical basal ganglia degeneration. When there is associated dementia along with the Parkinson's symptoms, then we will call it as diffuse Lewy body disease. So most of the time we will be able to make a diagnosis whether it is strictly strictly idiopathic Parkinsonism or Parkinson's disease, even in the initial cases. But ultimately, all IPD patients will have all these symptoms in the later part of the disease to some extent. Even idiopathic Parkinson's disease can have severe autonomic imbalance. Idiopathic Parkinson's disease patient can have dementia in the later part of the disease. But they will remain in this pattern for many years. For about 5 to 8 years, they will remain in this pattern, and only in the very late stage they will develop other symptoms. But Parkinson's plus syndrome, usually even the initial phases, they will manifest these symptoms. And most of the time, the treatment response also will be different. Idiopathic Parkinson's patient will respond better with the Syndrome, where other Parkinson's plus disease will not have much significant improvement with medicine, with modern medicine.
Among those Parkinson's plus syndrome, which will be have the worst prognosis, that means very fast progressing type, which makes the patient finally bedridden and dead.
I think it is supranuclear palsy. PSP will be having more difficult to manage. And compared to PSP, MSA is not very common. And diffuse Lewy body disease also, mostly it is behavioral problems and dementia. So from the management aspect, it is most difficult is PSP. They will have recurrent aspiration, recurrent falls. The main feature will be recurrent falls because of their vertical gaze palsy.
There is a differentiation of this disease based on the forward pathway, forward falling pathway. Is that true?
Because of the PSP, because of the severe truncal rigidity, mostly the fall will be backwards. And the Parkinsonism, because of the testinal gait, and because of the turning only, they will be falling. So, if the patient has got severe truncal rigidity, falling backwards, and for that matter, fall is a dominant, will not be an initial presentation and will not be a dominant symptom in idiopathic Parkinson's disease. It will be mostly PSP.
So you told me that the final stage, the final endpoint of forward Parkinson's, even idiopathic Parkinson's disease, is to end in any of these areas, that is cortical.
They can have, as a part of progression of the degeneration, they can involve any part of the neuroaxis and have symptoms. But that symptom will be the dominant symptom. It's with the dementia, IPD will not be as dominant as the dementia of the diffuse leaf body disease.
Sir, I think the investigations for this, especially imaging, is yet to be underdeveloping. There are certain doctors which are for suggesting SPECT scans and thyroid scan, etc. So can you brief about that?
Yeah, still the diagnosis of Parkinsonism is basically mainly clinical, and the investigations like CT and MRI is only to exclude other diseases. The PET scan and all are useful in the initial cases where there is to identify the areas of hypometabolism. So only in the initial cases it will be useful.
Okay, sir. So any other point to add in this particular spectrum where if you get a Parkinson's spectrum case, what all factors we need to keep in mind to prevent the worsening or to prevent immediate emergencies, especially in case of Parkinson's and Parkinson's plus?
Can you repeat?
That if we are getting a patient in the initial phase of Parkinson's plus syndrome, what all factors we shall keep in mind to prevent an immediate emergency or immediate worsening of the patient?
Yeah, one of the most dreaded complications in patients with IPD is that sudden stoppage of dopamine can cause neuroleptic malignant syndrome. If you see the patient is taking 3 tablets, 4 tablets of Syndopa, if you suddenly stop it for 1 week, the patient can develop a condition called neuroleptic malignant syndrome, which is very catastrophic and patient may succumb. And other thing that when the patient is idiopathic Parkinsonism or Parkinson's disease, if you add some drug which can exacerbate Parkinsonism, which can add to the predictive Parkinsonism, patient can have severe worsening of the symptoms, like for routine medicines that can be used for migraine, vomiting, like Differential, Reglan, and Nair-An. All these medicines can cause worsening of Parkinson's symptoms. So if you add such medicines, then there will be worsening of the neurological symptoms. And there are some medicines which can aggravate the side effects of Parkinson's syndrome, like if you add drug for brain prostatic hypertrophy, they can have an inherent risk of postural hypotension. The patient with Parkinsonism itself has got a risk of postural hypotension, and the Syndopa will add to the risk of postural hypotension. And in such patient, if you add tamsulosin and other drugs, it can cause postural hypotension and falls. So such patients, it will be very bad.
Sir, the drug being used to dyskinesia is also a CT. So what factors we have to keep in mind on observing that?
The predictors in this case are the most risky is that even if you stop some drugs, the dyskinesia will continue. Dyskinesia will continue for months to years. If you identify a drug that has caused the dyskinesia, especially oral antiviral dyskinesia, very disabling. There are many medicines which can cause, even the Nair-An which is used for migraine, or Ashtamgam used for migraine, and some levosulfide. There is a drug which is very commonly used by gastroenterologists for abdomen pain. The problem is that the doctor might have written the tablet for 15 days, and they will, whenever they stop the medicine, they will have again the symptoms. So they will continue even without prescription. So some patient will come after 2 years, and by the time the patient develops severe overventricular dyskinesia, and this will not improve even after stopping these medicines. So identify, and usually whenever you are prescribing medicine that has got extra side effect. You should make sure that these patients should not take this medicine for a longer time. You should closely monitor, and you should specifically instruct. You should not take this medicine without prescription continuously.
Now we are moving on to the spectrum of syncope. Just 10 more minutes. Can you brief us about the different varieties of syncope? How can we differentiate it?
Yeah. Syncope means basically is a cerebral hypoperfusion. So most of the time, there are different common causes of syncope is postural hypotension. When the patient is hypovolemic or anemic patient, whenever they are standing for a longer time, they can develop postural hypotension and there will be some graying of vision and fall. Otherwise, there is another the vasovagal syncope also, when the patient is in the crowded space for a longer time, especially when they are going for temple or some other functions, where there is lots of crowd and you have to stand for a longer time without moving, then they can develop vasovagal syncope. Otherwise, the syncope, there are two types. One is because of the cardiac arrhythmia or because of the cerebral hypoperfusion. So, in the evaluation of a patient with a syncope, and also you have to look for any medicine that can precipitate postural hypotension. And you have to look for clinically examine the cardiac rhythm and rate. If there is tachyarrhythmia or bradyarrhythmia, or you can evaluate further for any valvular heart disease. So, cardiac evaluation with ECG and preferably a Holter monitoring is a must for all patients with the syncope. And also, it's ideal to get a carotid Doppler to see the any critical stenosis. If the patient has got a critical carotid stenosis or vertebral stenosis, when they stand for a longer time or when they are deprived of water, they can easily develop syncope. Another differential diagnosis of syncope is one is seizure, and other is hysterical. Hysterical syncope is very common, actually more common than the true syncope. So, how to differentiate between these? Sometimes it will be difficult only, but in most of the hysterical syncope, patient will gradually fall and will make sure that they will not make any injury. They might have fallen down 50 times, but not that they have not made any injury. If the patient is standing here, if she falls, and she will make sure that she is falling in between this chair and she will not injure herself. And seizure is usually sudden fall, and most of the time they are prone to develop injury. Atonic seizure or drop attack, they can also suddenly, and they will not have any premonitory symptoms also. In the cardiac syncope, they can before the syncope, they will may feel that there is any abnormality in the heart rate. They will feel as palpitation and then some graying of vision, and then they fall. So history is very important, and history taken from an eyewitness is more important, because they will be able to just before falling what they did, whether there is an uprolling, whether there is any staring spell. All these are important to differentiate whether it's a syncope versus seizure.
Okay, sir. So the last and final terrain which we have left is seizures. So this is a broad division of the seizures, and what all factors we need to observe to identify clinically. And also from your viewpoint, if you take EEG, how can we differentiate different varieties of seizures?
Seizures in general are very easy to diagnose, and broadly you can classify seizure or partial seizures. Generalized seizure is generalized tonic seizure, tonic seizures. And the partial seizures are, which can cause some diagnostic confusions. So, unless the patient is very aware of the symptoms, patient will not be able to tell also. And the one classical example is juvenile myoclonic epilepsy, where the patient has certain jerking movements, which is there for many years. They will have these jerks even before the GTCS starts, especially when they get up early morning, when the sleep is deprived. They can have, they will develop these seizures and they will drop some objects in the hands. So, unless you specifically ask for the history of jerks, they will not tell you. This is more important because the juvenile myoclonic epilepsy, the treatment is very specific. That is, sodium valproate is the number one choice. And if you miss the history of jerks, and if the doctor prescribes carbamazepine or phenytoin for such patient, that can worsen the disease. So the history of jerks is, unless you specifically ask, they will not tell you. And also they can have jerks during sleep also. So this juvenile myoclonic epilepsy is very important to diagnose because the treatment is very specific. So also the absent seizures. Absent seizure, most of the time the diagnosis is done by the teachers. And they will feel that the child is not listening. These episodes are very brief and even the parents might have not noticed it. So the teacher notices when they are suddenly not listening in the classes. These can occur multiple times, 100 times, more than 100 times in a day. So specifically you have to ask for such brief episodes. Then only you will be able to make a diagnosis of absent seizures. And sometimes the absent seizure and complex partial seizures can get confused. But if you particularly ask the history, it is easy. The complex partial seizures, the numbers is not very much, 1 or 2 per day maximum. The absent seizure can develop 100 or 200 times in a day. And the brief episodes, the episodes are very brief, lasting for a few seconds in absent seizure, but in complex partial seizures, it's around 5 to 10, 1 minute or more than 1 minute, can last longer also. And usually associated features, lip smacking, automatism are common in complex partial seizure, which is not the real absent seizures.
Okay, sir, thank you very much. He was actually willing to be with us for more time, but unfortunately, sir has to leave for another session in Shornur. So here we end our session, and I heartfully thank sir to be with us. Actually, the session which we have now done is actually what is happening in our monthly neurology OPDs, which is happening, integrative OPDs which are happening in Ashtamgam. We sit in those OPDs and enjoy the clinical examination which Dr. Ravi sir is performing in patients and how he differentiates the different clinical situations right from the bedside. So I thank you, sir. Thank you very much for this wonderful session, and I invite Dr. Remya to have the final comments.
It's not about final comments, rather as a part of Ashtamgam team, I take this occasion to thank you, dear Ravi sir, for being with us for last 1 year. Because I must tell you, the journey of ours with Ravi sir came up very coincidentally. In 2023, we usually have an interaction with senior physicians with our students on July 1st, Doctor's Day, for last many years. So every year we used to call upon senior physicians to share their clinical experiences with our students, and we have been running this post-COVID till 2023. So in 2023, when we discussed with our peers, Ravi sir's name came up. and especially he was known for his yoga classes to the students. And as Ayurveda physicians, we are always, into inquisitiveness that what a neurologist can say, speak about yoga. And that was our intricacy, and we had contacted him, and sir was so positive to come and interact with students. And then after that occasion of interaction, and when we discussed the possibilities of Ayurveda, our limitations, issues, and it was after some discussions that this the integrated possibility that was already in our mind, right from our post-PG days, during our initial years at Pachnikadu Ayurveda Medical College where I was working. And we had similar interactions with Dr. Sujit Ovalat, who is now in Nanjaragandi Medical College and MEMS Calicut. So similar things, so he was very positive, why can't we, you have to explore more. So we came up with the idea of integrated neuro-OP, and we approached him that, sir, would you be able to come to us, and we together sit, and he was very positive. And we started the integrated neuro-OP with respect to the World Parkinson's Day 2024, and we started it on an auspicious day, April 20. So from that month, every first and third Saturday, sir is coming to us, myself, Dr. Rahul, coming together with sir to see cases, and all other guys, Nidhanam, and doctors are supporting whenever are needed basically. And then along with that, after 3 or 4 months, we actually had and sir was very inquisitive to interact with our students. So we started a clinical neurology certificate course for our interns, and whoever were interested, because who were interested to spend time, have serious concern about students, go back and read. So we started a certificate new, and I think 14 of our interns and our medical officers had enrolled in the program. And we were continuing the program. We are into the last part of the program, 40 hours, 40 classes program. So every week, like every alternate weeks, after the neuro-OP that happens for almost 2 hours, next 2 hours we used to have neurology, clinical neurology classes with the integrated clinical neuro certificate course students. So it runs up to 7:30 in the evening, and sir used to be with us. So I think on behalf of all of us over here, sir, Ashtamgam family, our students, interns, and I think the whole group over here, I take this opportunity to thank you for being with us, and I wholeheartedly pray that with Lord Manvanthari's blessing, we continue the journey so that many more patients. I just conclude with one clinical experience. I still remember an M&D case with wasting coming to us. And coming to the OPD, and I had admitted him, and he was a worker in kitchen, Gulf or something. He was having, I was thinking it to be fasciculation. His muscle was wasting and it was fasciculation, and I was telling sir MNDLA. Of course it was unilateral on the primary thing, but muscle wasting was the conspicuous muscle wasting. So I meant fasciculation in this arrest. So naturally we have to consider, of course it was a severe cervical myelopathy case. So sir, that is not fasciculation, Ramya. Other wasting on the brachial artery pulsation. So this was actually very specific identification. So that touch ചെയ്തിട്ടില്ല, നമ്മൾ കാണുന്നേ ഉള്ളൂ. Okay, കാണുമ്പോൾ ഈ fasciculation brachial artery ഇതുപോലെ വ്യത്യാസം വരുമെന്ന്, that was one point that was clicking. So how important it is to see many cases and then speak. That's very important. And I still remember a case who had come out with human lesions, all this Parkinsonian, expressionless, facing difficulty to walk, burning sensation, we were wasting, all coming up together. We were under speculative diagnosis. Such case was admitted only with sir's support, and then we had excluded MND, Parkinson's. I think that patient who actually later was diagnosed as Prion's disease, CGD and CJD, and then he had succumbed later. So it was a multiplex. I think it was the first time that I had seen the case over here. So such cases we could admit and all only because of the strength that we have, that he is there to manage any emergency when it can happen. So we are really thankful to you, sir. Sir, at every point, Ratri anengilum, Ravale anengilum, whenever I call him, sir,
he takes up the calls and tells me, sir, for medicine. And with his help, we were able to taper medications whichever is not needed. People with 10 plus tablets were tapered to 3, 4 with his help, and we supported. And wherever it has to be supplemented with his support, we add on medications if it is needed. So that possibility is moving on. So we are thankful, sir. Thank you so much.
Thank you, sir. As a token of our love and gratitude, on behalf of Ashtamgam family, I invite Dr. Nair-An, Professor, HOD of Panchkarma Department, to honor our guest. I also invite Dr. Vidyapeedham to receive the honor. Sir, please.
Okay, thank you all.